one of our standardized patients at Loyola. The purpose of this video is to introduce first-year medical students into steps that are relevant to the head and neck physical examination. At the same time, we hope to reinforce surface anatomy, which you recently learned in your structure class. Of course, before we begin any examination, it's always important to wash our hands. So first I'm going to go ahead and wash my hands. The first part of the examination is to simply inspect the head and neck area. Note any obvious deformities, asymmetry of the head, any scars that might indicate a prior surgery. Of course, if a patient's wearing a wig or a toupee, as many cancer patients do, ask them to please take that off. Otherwise, you cannot do an adequate assessment of the head. You're going to be noting hair distribution, noticing if there's any loss of hair, and then what the pattern of that hair loss may be. And then you're going to palpate the skull. And simply just to place your fingers on the scalp. Nancy, does any of this hurt?
No.
At the same time, you can notice if there's any obvious deformities of the scalp. Sometimes to get a closer look at the scalp, if you simply take your thumb and pull the hair back against the way it's laying, you can get a closer look at the scalp to notice if there's any lesions or scaling of the scalp. You will learn as you progress through medical school that there's certain sort of characteristic facies or facial appearances that are associated with certain diseases. And I can refer you to the chart in the back of the chapter in Bates for further information on that. The next step we're going to do is to examine the range of motion of the neck. And there's three different movements that we're going to be assessing. So Nancy, can you touch your chin to your chest? That's testing flexion. And then tilt your head all the way back. And that tests extension. Good. Next, I'm going to ask you to move your chin towards your shoulder. So that lateral rotation is about 60 to 80 degrees. Then towards the other side. Good. And then if you could tilt your ear towards one shoulder and then the other. Good. And those would be the three different ranges of motion you'll assess. Of course, you don't want the patient to lift their shoulder up to their ear or lift their shoulder up to their chin. That's not really assessing neck motion. The next part of the examination is to assess the parotid glands. Now, the parotid glands are one of those sets of salivary glands, and they're the largest of the three salivary glands. The parotid gland is approximately triangular in shape, with the base of the triangle over the bony prominence and the apex pointing down, with sort of a diagonal line connecting the apex with the base. When you palpate, use the pads of your fingers and simply roll your skin, or roll the patient's skin underneath that area. You might note if there's any symmetric or bilateral enlargement, if there's bilateral pain, as is found with a viral infection known as mumps, or if there's a unilateral swelling or nodule in the parotid gland. The next set of salivary glands that we ask you to assess for is the submandibular glands. They're about half the size of the parotid gland. They lie below and anterior to, this is the angle of the jaw. The submandibular glands lie about halfway from the tip of the mandible to the angle of the mandible. So again, just by using the pads of your fingers, and sometimes it helps if the patient flexes their head just a little bit, you can feel the submandibular salivary glands. Good. Of course, the submandibular glands drain into the base of the mouth at Wharton's ducts, and the parotid glands drain as Stenson ducts near the second upper molar, and we'll review that a little more thoroughly when we do the mouth examination. Next, we ask you to assess for the superficial temporal artery. This artery is a continuation of the external carotid artery, and it emerges from the parotid gland just in front of the ear, but behind the temporomandibular joint. So this is roughly the area where it emerges, and then it runs up into the temporal fossa for approximately 5 centimeters. Oftentimes in elderly patients, it's a very obvious artery. You can almost see the pulsations. And oftentimes in older people take sort of a serpentine or snake-like or tortuous course. Again, just by placing my finger pads over the temporal bone, There we go. Now I can feel the temporal artery pulse on both sides of Nancy's face. The next part of the examination we're going to ask you to assess is the mouth. And to do the mouth, you need a light source as well as you need a tongue blade. Some students ask, do they need to automatically put on gloves to do this part of the examination? You only really need a glove if you would visualize an abnormality within the mouth or the oral mucosa, and then would need to palpate that. And of course, you need a gloved hand to do that. So for the routine examination, you don't need to put on gloves. And when you do ask the patient to open their mouth, you don't want them to open all the way as wide as possible. Just open their mouth so that you have some room to play with their cheeks, and move the cheeks laterally with the tongue blade, as I'll demonstrate here now. The first thing you'll notice is just to assess for the teeth. And what you'll notice, of course, adults have 32 teeth, 16 in each jaw. You're going to be noticing if the teeth are present or absent. You'll be looking for evidence of dental caries or infections. If the patient has dentures, you'll ask them to please remove those dentures for the examination. Next, you're going to examine the mouth or the gingiva. And you need to pull back the mucosa to examine the gingiva. You're going to be looking for evidence of hypertrophy, swelling, or bleeding. Next, you're going to ask to examine the patient's tongue. So Nancy, can you stick out your tongue? When the patient protrudes their tongue, it should be in the midline. Nancy, if you touch your tongue towards this side. If when you ask the patient to stick their tongue out, it protruded towards one side or the other, that would indicate that there was a lesion or damage to the hypoglossal nerve, or the 12th cranial nerve, on that side. And with time, the tongue muscle would atrophy on this side if there was a lesion on that side. When you observe the tongue, again, if you stick out your tongue, Nancy, you're going to be looking for any ulcers, lesions, or white patches. Of course, in smokers and tobacco users, cancer of the mouth is common, and cancer of the tongue is in fact the second most common cancer of the mouth. Nancy, can you touch your tongue to the roof of your mouth? Examine the undersurface of the tongue. And then can you touch your tongue to this side? Now I can examine the whole side of her tongue, and then to the other side. And again, with a good light source, I can examine both sides of the tongue by simply asking the patient to touch each side of their cheek. Next, we're going to identify the ducts that drain the salivary glands. First, let's identify Stenson's duct. By pulling the mucosa out, you can identify a papilla near the second posterior molar, there it is, that drains the parotid duct. To identify Wharton's duct, which drains the submandibular glands, actually, Nancy, can you tilt your head forward just a bit for the camera, and then lift your tongue up? At the base of the tongue, you can identify papillae, which is where Wharton's duct drains. Next, you're going to be examining the uvula, anterior and posterior pillars, the tonsils, and the soft palate. And to do this, Nancy, I'm going to ask you to open up your mouth and press the tongue blade about halfway in the tongue, and then press down. The uvula obviously is in the midline of the soft palate, which hangs freely from the middle of the soft palate. On either side of the mouth is the anterior and posterior pillars, and in between that is the tonsils. The tonsils, of course, are the lymphoid tissue, which gradually decrease in size after age 5. So tonsils are most prominent in children. The soft palate makes up the posterior third of the arched roof of the mouth. First of all, we're going to assess the auditory division of cranial nerve 8. Simply by holding your fingers about 3 inches away from the patient's ear in a quiet room, and then rub those fingers together one at a time and ask the patient to point to which side they hear. So Nancy, which side do you hear? Good. So just a simple test like that can screen for hearing.
There is no simple way to test for distinct motor function of cranial nerve 9. The presence of a gag reflex tests for cranial nerve 9, but of course you do not want to induce a gag reflex in a patient. To test for the motor function of cranial nerve 10, ask the patient to say ah and watch for the uvula and soft palate to rise upward in the midline. There should be no deviation of the uvula from one side to the other if the vagus nerve is intact bilaterally.
To check for the spinal accessory nerve function, or cranial nerve 11, place your hands on the patient's trapezius muscles. Then just ask them to shrug up their shoulders against your resistance. Good. And you should feel a symmetric rise in equal strength between both trapezius muscles. An alternative way to check that is to ask the patient to turn their head against your hand. Good. And the other way, Nancy? Good. And that's checking for a function of the sternocleidomastoid muscle, which is innervated by the spinal accessory nerve. And remember, we checked for cranial nerve 12, the hypoglossal nerve, when we asked the patient to protrude their tongue. So we've now examined the cranial nerves that are relevant to the head and neck exam. It's important to inspect the whole external ear for any lesions and actually pull the ear forward and pull the ear down to check the top of the ear surface. In people who have short hair, oftentimes there can be sun-exposed skin in this area year-round, and you might pick up a sun-damaged skin or even a skin cancer. The ear is mostly made up of cartilage. The lobule of the ear, however, at the bottom is not made up of cartilage. The outer rim is known as the helix. The inner rim is known as the antihelix. The tragus is in front of the external auditory meatus. The external auditory canal is approximately 2 to 3 centimeters long in adults, and it ends in the tympanic membrane.
Although I only demonstrate the otoscopic exam on one side in this video, remember that this exam must be performed on both ears.
To perform the otoscopic exam, you of course need the otoscope. And before you begin, make sure the light source works by checking that the light is on. You'll notice at the base of the otoscope, by rotating, I can vary the intensity. And of course you want this as bright as possible when you're doing the otoscopic exam. Take an ear speculum and place it on the otoscope until it sort of locks in. And of course you want to use, if you have a choice of ear speculum, use the largest speculum that can fit into the patient's ear. You do want to stand close to the patient, be next to the table. Nancy, can you sit up straight? By improving the posture of the patient so that my eye level is almost at the ear level, the examination goes much more smoothly. To visualize the tympanic membrane, you're going to grab on the top part of the pinna or the auricle of the ear. You're going to pull up, back, and out. Again, up, back, and out. And gently insert the speculum into the ear to visualize the tympanic membrane. And by moving just up and down and tilting different angles, you can pretty much visualize the entire tympanic membrane.
In the majority of patients, pulling the ear up, back, and out allows you to visualize the tympanic membrane. However, in some patients, anatomy varies, and you may need to pull the ear in a different direction to visualize the tympanic membrane.
There is thin skin lining the ear canal, and this can be painful, so make sure that as you do this examination, the patient's not experiencing any pain, and certainly warn them before you put the speculum in to do the exam. Now, the tympanic membrane might be occluded by cerumen or earwax, by purulent discharge if there is an infection. So again, be careful when you do insert the speculum into the external auditory meatus. The neck is actually divided into 2 triangles by the sternocleidomastoid muscle. The sternocleidomastoid muscle begins approximately from the mastoid process of the temporal bone and runs diagonally towards the clavicle and sternum, and actually divides into 2 heads. The sternal head is medial and attaches just above the manubrium of the sternum, and then the clavicular head is lateral. The anterior triangle is bounded by the sternocleidomastoid muscle, the mandible, and then the midline of the neck. The posterior triangle of the neck is bounded by the posterior border of the sternocleidomastoid muscle, by the anterior border of the trapezius muscle, and then by the clavicle. Next, we're going to ask you to identify the external jugular vein, and to do this, it helps to have the patient in approximately a 30 or 45 degree angle. So Nancy, if I can have you lay back for me. The external jugular vein actually begins in the parotid gland and runs inferiorly behind the angle of the mandible down over the surface of the sternocleidomastoid muscle. By simply placing your finger against the clavicle, you can oftentimes make the external jugular vein become more prominent by preventing its drainage. Alternatively, you could ask the patient to strain as if they're having a bowel movement. This is known as a Valsalva maneuver, to strain against a closed glottis. And if they do that and hold that strain for about 5 or 10 seconds, the external jugular vein will also become prominent. So Nancy, can you bear down and strain for me? And again, you can see the external jugular vein becoming prominent. Good, thank you. You can release that. The hyoid bone is a mobile bone. It actually does not articulate with any other bone. It's just below the mandible in the crease between the neck and the chin. It's a U-shaped bone. Actually, if you tilt your head forward a little bit, Nancy. By palpating more laterally, you can feel the bone and move it side to side. It's above the thyroid cartilage, and it's approximately the level of C3 and C4 in adults. Next is the thyroid cartilage, which is below the hyoid bone in the midline. It's more prominent in men and becomes more prominent at the time of puberty. In layman's terms, we'd call that the Adam's apple. You can identify it by a V-shaped notch of the cartilage in the midline, which I can palpate. I know this is a little uncomfortable, Nancy, but palpate right there. Below the thyroid cartilage is a cricoid cartilage, which is approximately the level of C6, or the sixth cervical vertebra. And then at the base of the neck and the midline is the sternal notch, which lies just above the manubrium of the sternum. By placing your index finger posteriorly and somewhat inferiorly, you can identify a pulsation from the aorta in this general area. Also, the trachea is in this area. By placing your finger just to the lateral of the midline, you should be able to move your index finger in a groove in between the sternocleidomastoid muscle and the midline trachea. And the trachea should be mobile. It might be shifted slightly to the right, and that's normal. But there should be an equal ability to place your index finger in that groove between the sternocleidomastoid muscle and the trachea. The trachea begins at the level of the cricoid cartilage at C6 and ends about the fifth thoracic vertebrae, which is approximately the angle of the sternal angle, or the angle of Louis, where it divides into left and right bronchi. The thyroid gland is the largest endocrine gland in the body. It usually lies about the level of the fifth cervical vertebrae to approximately the level of the first thoracic vertebrae. It's divided into two lateral lobes and a midline isthmus. And the isthmus is approximately the level of the second or third tracheal ring, which is of course below the cricoid cartilage. To assess for the thyroid gland, most of the times we examine the thyroid from the posterior by placing our hands from behind the patient. Some people also examine the thyroid anteriorly, and whatever method you feel most comfortable is fine. But I'm going to demonstrate the method from the posterior. It's often easier to assess the thyroid gland too when the patient swallows, and many patients cannot swallow on command. So let me just grab a glass of water here. And Nancy, if you can just hold this in your hand. I'm going to first locate the cricoid cartilage, which is below the thyroid cartilage. Now that I've located that, I'm going to place the pads of my index and middle fingers approximately in that area. Sometimes it helps to have the patient extend their head, so you can tilt your head back just a little bit, Nancy. And go ahead, can you take a sip of water? And then go ahead and swallow. Good. And as the patient swallows, the thyroid gland rises up against the pads of your fingers, and as the swallowing is completed, the thyroid gland falls back down again. And that's what you're actually trying to palpate. As the thyroid rises and then falls against your finger pads. Again, assessing for the thyroid gland is not an easy maneuver. And you may need to actually place your fingers in a few different positions and have the patient swallow multiple times to try to palpate for the thyroid. It's usually easier to palpate a thyroid gland if a patient has a long, slender neck than if they have a short and stocky neck. Certainly you're going to be noticing if there's any asymmetry between the two lobes of the thyroid, if there's any nodule in either lobe of the thyroid. That's part of the thyroid examination. Next, we're going to identify the lymph node groups in the head and neck area. Again, you want to use the pads of your fingers and not your actual fingertips when you examine for lymph nodes. You don't want to just be poking and jabbing at the patient. Place your finger pads down against their skin and make sort of a circular motion to move the subcutaneous tissue, and if there is a lymph node, to move it underneath your finger pads. Lymph nodes normally should move both up and down as well as laterally. And that can sometimes help if you're not sure if you're palpating a muscle or an artery or a vein or a lymph node. So again, lymph nodes should move both laterally and up and down. When you examine for lymph nodes, and if you find lymph nodes, you're of course going to note their size, their mobility, how easily they move back and forth, the consistency of the lymph node, whether it's hard, soft, or fluctuant, whether the lymph nodes are tender, and of course you need to ask the patient if that's sore, if that hurts. And then finally, whether or not the lymph nodes are discrete and unique, or whether they're matted together in a group. Remember, each set of lymph nodes drains a different part of the head and neck. So first, let's examine for the pre- and post-auricular lymph nodes. You can do this simultaneously by just placing your fingers just in front of the tragus of the ear. Make the small circular motions for pre-auricular lymph nodes. I don't feel any. And place your finger pads behind the ears over the mastoid bone to palpate for post-auricular lymph nodes. Next, you're going to assess for occipital lymph nodes, which are at the base of the skull. So again, by just pressing in the base of the occiput, the top of the neck, you can assess whether or not there's any occipital lymph nodes. And I don't detect any, Nancy. Next, we're going to assess for the submandibular lymph nodes, which are found about halfway between the angle of the mandible and the tip of the mandible. So again, by placing your finger pads in this area, you can assess for submandibular lymph nodes. And notice that they would be superficial to the submandibular gland, which is a little bit more lobulated and an irregular surface, whereas any lymph node in this area would tend to be more round or ovoid. The submental lymph nodes you can also often palpate just with one hand, and it's just behind the tip of the mandible. Then we're going to assess for superficial cervical, which are actually lie over or superficial to the sternocleidomastoid muscle. So you do need to move your fingers over the course of the sternocleidomastoid muscle to feel the superficial cervical. The posterior cervical would be felt along the anterior border of the trapezius muscle. Again, I don't feel any posterior cervical lymph nodes. Then finally, the supraclavicular lymph nodes, which are found in the angle formed by the clavicle and the clavicular head of the sternocleidomastoid muscle.